Hello, it's Michi Shinohara, Service Director for University of Washington Dermatopathology, and this is part of our Dermatopathology Didactic series. This is an intro to Dermpath lecture. I want to review some common structures seen in the skin and review some common terms that are referred to, as well as talk a little bit about the importance of clinical pathologic correlation. One of the first structures that I want to talk about are eccrine coils, eccrine glands. These are basically sweat glands, and they're seen in the skin as small glands or tubes that generally open into the epidermis. You can see collections of them as seen here, and they are present almost anywhere on the body, but they are more prevalent in certain areas that are very sweaty: hands, feet, armpits, groin. Apocrine glands are seen here on the right, are characterized generally a little bit larger than eccrine coils, but characterized by decapitation secretion. They are present in only specific anatomic locations like the armpits, the nipples, eyelids, and the external auditory canal. This diagnosis happens to have both adjacent. This is a nevus sebaceous, which has atopic apocrine glands present, usually on the scalp. Another structure that I want to review are the pilar or erector pili muscles. These are the muscles, little muscles that are responsible for elevating your hair on your arms, for example, when you get the goosebumps. They're seen here, generally present in the superficial to mid dermis in bundles. A higher power look at that, showing characteristic smooth muscle morphology with that perinuclear vacuole, kind of bubbly cytoplasm. To review some common terms in Dermpath, I want to start with acantholysis and dyskeratosis because they happen to both be present in this diagnosis. This is Haley-Haley, and it is a diagnosis that has prominent acantholysis. Acantholysis refers to dissolution of the interkeratinocyte adhesions, so basically falling apart of the epidermis. And in this example, we also see some dyskeratosis present there. These are also called dead reds. These are keratinocytes that are in the process of going generally through apoptosis, and they are anuclear cells. So acanthosis and dyskeratosis. Acantholysis and dyskeratosis. Now we have acanthosis. Acanthosis refers to thickening of the epidermis. This can be regular or irregular. It can be psoriasiform. This is a great example here of psoriasiform acanthosis. This is psoriasis, and it shows thickening of the epidermis, pretty marked with kind of even width of those epidermal rete. Acanthosis can also be irregular, as in this example. This is lichen planus, showing kind of thick, thin, jagged looking rete. And here's another example of irregular acanthosis. This is pityriasis rubopilaris, showing kind of blunted rete. But regardless, acanthosis, thickening of the epidermis. In converse, we can have effacement of the epidermal pattern, shown here. Effacement is loss of the epidermal rete pattern and generally thinning of the epidermis. This happens to be a variant of basal cell carcinoma, fibroepithelium of Pincus, and it also shows some retraction artifact shown there in the left. And we've got solar elastosis that's present in sun-damaged skin. It's a consequence of photo damage, and it generally shows up like gray to purple change of the elastin fibers that look chewed up. Some of them are thick, some of them are thin. They're very disorganized. This has a squamous cell carcinoma in situ that you can see overlying it, usually caused by sun damage, so makes sense we might see some solar elastosis there. Exocytosis and epidermotropism are cousins. They're basically the same, different terms for the same thing. On the left, we have exocytosis of some eosinophils here and probably some lymphocytes there. Any type of cell can be exocytosed into the epidermis, but most commonly we see lymphocytes, probably followed by eosinophils and then maybe neutrophils. In the specific example of mycosis fungoides or Sézary syndrome, we can see exocytosis of atypical lymphocytes. seen here in some clusters, and then kind of tagging along the dermal epidermal junction. When we see exocytosis of atypical lymphocytes in cutaneous T-cell lymphoma, we call it epidermotropism, but that's just a very specific example of that. Erosion and ulcer are on a spectrum. Erosion is partial thickness, loss of the epidermis, whereas ulcer is full thickness, meaning going into the dermis. What that looks like histologically on the left here, we've got an erosion, almost a pustule, with retention of a few layers of the base of the epidermis. And on the right, we've got full thickness loss of the epidermis in that ulcer. Hyperkeratosis comes in two flavors. We have orthokeratosis, which is thickening of the epidermis, of the stratum corneum without retention of nuclei. This is hyperkeratosis of the orthokeratosis variety. And then you can have hyperkeratosis of the perikeratosis variety, which is thickening of the stratum corneum with stratum corneum that has retained nuclei, as in this example, which happens to be psoriasis. Perikeratosis can be kind of continuous across the whole epidermis, as in that last example of psoriasis, or it can be focal. This is an example of mounded perikeratosis near the hair follicle. Shoulder perikeratosis, another term for that. This is seborrheic dermatitis. Then hyalinization is a dermal change that refers to loss of the dermal collagen bundle structure. Looks like it kind of got ironed out. Can look a little edematous sometimes. We can see that here in the superficial dermis, that hyalinization of the collagen pattern. This is lichen sclerosus. Papillomatosis, wart-like, means kind of a bumpy, undulating pattern of the epidermis. Pseudoepitheliomatous hyperplasia or pseudocarcinomatous hyperplasia refers to changes of the epidermis that look like squamous cell carcinoma, but generally are not. They often overlie other entities. In this example, the pseudoepitheliomatous hyperplasia overlies a granular cell tumor, but you could also see it as a reactive pattern. Tricholemal differentiation refers to differentiation towards hair follicle epithelium, and the hallmark of that type of differentiation is that the epithelium does so without a granular layer. So here's a higher power look of hair follicles, polyanogen hair follicle, showing differentiation. Here's where the granular layer would be, but instead we've got this hair cortex, and we have tricholemal differentiation without a granular layer. You can see that in non-hair follicle structures, some tumors that show tricholemal differentiation. This is a pilomatrachoma. And normal epidermis shows that differentiation with a preserved granular layer. But in this example, where we've got, normally we would see a granular layer here, we've got differentiation without that. Just as an aside, we'll often see hypogranulosis with perikeratosis overlying it, like in this example. There are three flavors of viral cytopathic change, probably more, but three that we're going to talk about. We've got human papillomavirus type, we've got herpes group type, and ORF. The viral cytopathic change that's typically seen in human papillomavirus classically shows hypergranulosis, so very prominent granular layer with these clumped irregular granules, coilocytes, which are vacuolated keratinocytes, these examples here, with pycnotic or small raisin-like nuclei. This is an example of a myrmecial or plantar wart showing really marked HPV viral cytopathic change. A caveat is that some variants of warts, condyloma and flat or planar warts, often show very subtle or absent viral cytopathic change. This is a condyloma. The viral cytopathic change seen in herpes group infections is a little bit different. Tends to show margination of the nuclear chromatin that's called eggshell chromatin. A couple examples here. I'll show you high power in a second. And then multinucleation as well as eosinophilic nuclear inclusions. So it's a great example here of that eggshell or peripheral chromatin and then some multinucleated cells there. Then the viral cytopathic change seen in ORF is kind of an extreme example where you have ballooning degeneration. You can see that in other things too, like herpes group sometimes, but very dramatic here in this example of ORF, where you see remnants of the keratinocytes, kind of being pulled apart, especially from the basal layer. And then sometimes you can see eosinophilic nuclear inclusions as well. All right, clinical pathology correlation in Dermpath is super, super important. Having clinical history improves diagnostic accuracy, and it's very common that having knowledge of the clinical situation could change the diagnosis. And I want to show you a couple examples of where that might play out. This is a case of a melanocytic lesion. We see a junctional proliferation and a couple dermal nests of these atypical, highly pigmented melanocytes that are confluent along the dermal epidermal junction. There's some separation of the epidermis from the dermis. We call that malignant zipper sometimes. But what we also see is a little bit of scar or fibrosis underneath. The history here, so you may be tempted to call this a melanoma in situ, maybe with the dermal component as well. But the history here is that this was a previously biopsied benign intradermal nevus that had some pigment regrowth. And so the biopsy site was re-excised. So this is an example of a recurrent nevus phenomenon or pseudomelanoma. So very important clinical history there. Here's another example of a lymphoid infiltrate that's kind of a dense dermal, a little bit of ulceration on the top, very dense dermal lymphocytic infiltrate, perhaps a little epidermal involvement here as well. Higher power look showing some large, highly atypical lymphocytes that happen to be T cells. Higher power view there. And a CD30 stain, strongly positive in a substantial portion of these. So you might think this could have a differential of a CD30 lymphoproliferative disorder, lymphomatoid papulosis, cutaneous anaplastic large cell lymphoma, even transformed mycosis fungoides. However, the clinical history is that the patient has an itchy rash that has been present only for a few weeks, very prominent between the fingers, on the wrists, and on the abdomen. And this patient was in her 50s. Her adult son had just returned from college, and he had scabies. And so she likely also had scabies, as demonstrated by a scraping. So this is CD30 lymphoid hyperplasia due to scabies. Very, very critical clinical history that changed things quite dramatically. And lastly, I'm going to show you a case where we have this very intense lichenoid infiltrate, a lot of acanthosis, really irregular, some eosinophils in the superficial dermis. And so a differential was made here of a lichenoid drug eruption, perhaps if this is a single lesion, a benign lichenoid keratosis. About some clinical histories, the patient has a new widespread rash that does look somewhat lichenoid clinically, very dramatic. On the backs of the hands, you can maybe even see what's called Wickham stria here, which are these white lacy change. And the history is the patient actually has metastatic lung cancer and was started on a checkpoint inhibitor and developed this very brisk rash, which is likely a lichenoid reaction to checkpoint inhibitor. So if we didn't know that this was a rash, we might call it a single lesion, benign lichenoid keratosis, for example. But with the clinical history, we can come to a better diagnosis. So that sums up just a quick whirlwind introduction to Dermpath, structures, terms, and the importance of clinical pathologic correlation. And I hope you enjoyed it. Thank you very much.